Hello, my name is Dr. Heather Tick, and I'm with the University of Washington, and I'm an integrative pain doctor. And I'm just going to talk today about some different ways that we can think about pain. This is what we wish we knew, with all the pieces of the puzzle in the right place, and we had a really excellent understanding of how everything works. But this is actually more like what we know, with some of the puzzle pieces in the right place and many of them still uncertain. And so all we have to do is look at the recent history of pain medicine to know that this does represent where we are. It's only within the last 10 to 15 years that we have recognized that men and women actually feel pain differently, that it is processed differently in their brains, in their cell types, using different communication molecules. And so, what we have through science is partial knowledge. And if you want another example of that, in the year around 1900, one of the great scientists in Britain had said very dogmatically that heavier than air flying machines are impossible. And just think of how far we've come. And if you look at the history of the diagnostic manuals, those are our how we do our diagnosis. That gives us the outline for those. They have changed drastically in just the last 20 to 30 years. And just go through some of the changes that have taken place. They're drastic. And so it's an acknowledgement that we are an evolving science, like all science is. There's a series of studies going back in data for about 50 years that I have listed here under iatrogenic disease. And what they have all shown, the statistics have not changed in those 50 years, that in modern medicine, and the studies were done in the US data, modern medicine, hospital medicine, is the third leading cause of death in North America. And that is a stunning statistic, because none of us who went into healthcare did so with the dream that we could possibly be part of something that dangerous to people. And so, even though we have so much advance that has taken place in modern medicine with many life-saving strategies and techniques, and in spite of that, there are things that we are doing in our medical practice that are mistakes, that are side effects, and they are having a dramatic impact on mortality and morbidity. And so we have to look at what's the best we can do. And what is becoming more and more recognized is that low risk, low tech options have a lot to offer. Acupuncture, for example, is safe and effective and really has extremely low risk. So, when we look at the challenges of pain medicine, we are faced with complex phenomena that our patients present to us. And we try to distill that into algorithms, and that's our diagnosis. But a diagnosis is a concept, and a concept is, for example, a tree. If I say I'm thinking of a tree, what do you think I'm thinking of? Is it a bonsai tree? Is it an oak tree? Maybe it's a family tree. So concepts ignore individual details that lie outside the algorithm. And inevitably, there are findings in our patients that don't fit the algorithms. So what do we do? Our habit has been to ignore them, to pass over them and say, well, we can't, have all the criteria met. But we don't benefit then from looking at those outlier points and thinking about why that might be. And when we do that, we welcome complexity and uncertainty, and that also is what leads to medical insights. The outlier points are really important to advance our knowledge. Silos and algorithms have, as I said, led to medical miracles, but we have to take into account the horrendous rate of iatrogenic disease. When we experience acute pain, it is the brain that has decided that we are experiencing a life-threatening situation. It is a danger alert system. It is a measure of not amount of sensation, but of amount of significance towards our survival. It's a call for urgent action. All pain is experienced and perceived by the brain. If we have no brain, we can have no pain, and therefore the brain can modify the experience. We don't have pain receptors. We have nociceptors, receptors that experience noxious input from temperature, pressure, or chemical detection sensing, which is as a result of tissue damage. And then the brain interprets the level of risk or danger. Now, what happens if you are running on a sprained ankle, but you need to keep running after the prey animal that is going to stave off your starvation? Well, your brain has central and peripheral inhibitory pathways that can modify the sense of urgency that you're going to feel. And as a matter of fact, you may not even feel pain until after you're sitting around the fire eating what is now your dinner. When it comes to chronic pain, it's not just how long people have it, it's also the mechanism. Sometimes the mechanism of why people have ongoing pain is ongoing nociception, which is basically like ongoing acute pain. And when it comes to the musculoskeletal system, especially the soft tissues like fascia and muscle, we don't have really great testing for figuring out what's causing those conditions, and we might miss them. It can be a change in brain processing as well. And so there's a failure of the descending and central inhibiting processes that are supposed to let us know when we're not in danger from the pain we're having. Part of that is a process called sensitization. So now let's take a moment to talk about why it is we get chronic pain. Well, it used to be thought that chronic pain was maladaptive, that it was something going wrong in people's brains. But in fact, it's something going right in people's brains. We have the genetic systems, the enzyme systems, the detection systems set up so that we will experience chronic pain because it helps us survive. It makes us less vulnerable to predators because we're more cautious. And in this study done by a group at Temple University, they found that actually using analgesics is counterproductive for chronic pain, and it delays recovery. So the brain is a master connector. And therefore, pain psychology has had enormous success. But it doesn't mean that just because psychology and psychological strategies are helpful for treating chronic pain, and they are enormously helpful, that it is all a psychological problem. Because we can't really distinguish the psychology and the physiology because they use the same neurotransmitters, the same systems of communication and in recognition of inflammation. And so there are a great many connectors in our system, and this is several of them that you can pause this video and look at and take note of if you're interested. And these connectors are all basically operating in the same pot of soup with the same ingredients. And so now, how should we deal with the situation that we have in pain medicine? Well, there's a tremendous amount of literature, of good evidence-based non-pharmacologic literature, looking at strategies for dealing with chronic pain that can be effective and low risk. And so I urge you to look at the other videos in this series that give you little appetizer sizes of some of those strategies, and to look at the literature. Thank you.